Invite the next speaker, Dr. Hrishikesh, and he's going to speak about practicing changing news in respiratory and cardiology. Dr. Hrishikesh Jha. Dr. Hrishikesh Jha is a consultant critical care specialist. He's from HCG Hospitals, Ranchi. Over to you.
Thank you very much. I would like to thank the organizers at the outset, Dr. Pradeep Rangappa sir and Dr. Ajit sir. I've been asked to talk on practice changing newer things in cardiology. There were a lot of things that I initially thought that I could have touched upon. But to me, over the past 2 years, the most significant thing that's developed in cardiology, especially for usage in critical care settings, is something called as VEXUS, or a venous excess score based upon ultrasound findings. As clinicians, the first reaction that we have whenever we face a patient is to give him fluids right away. The first thing that we are always taught is institute an IV line and start with fluids, whether there is a documented negative fluid balance or not. There's always a hemodynamic signature associated with each of the various types of shock that we encounter in our patients. However, the reflexes that we develop during our course of practice is such that whether the urine sodium is less than 20, we go ahead, give fluids. Whether there is hypotension, we give fluids. AKI, give fluids. If we find lung sounds clear on auscultation with hypotension, give fluids. Elevated lactate, give fluids. Today being the World Water Conservation Day, I think we could not have got a better opportunity to talk on how to save on water even in our patients. Our patients could be either an inundated ocean or dry as a desert. Both the inundation as well as being dry are deleterious to the patient, as had been shown by a study by Dr. J.L. Windsor. Hypovolemia or hypervolemia, both are equally bad. Hypovolemia leading to altered tissue function, perfusion, renal failure, anastomotic leakages, confusional state, risk of a CVA, splanchnic ischemia, and finally ending as a multi-organ failure. Hypervolemia can lead to edema, intra-abdominal hypertension, respiratory failure, impaired healing, altered mentation, and MOF as well. The basic flaw that we have been brought up with, it actually and invariably leads to the global increased permeability syndrome that we land most of our patients in, given the tenet that if you need to cure a patient, you need to first swell him to get him well. However, things have been changing. First has been the impact of the extended Starling principle, which has been propounded lately, wherein it has been proposed that whatever that we had been taught during our MBBS days about capillary and the permeability and the hemodynamics of capillary exchange do not actually exist so as had been practiced over the past 50 to 70 years. We need to remember that tissue perfusion pressure is not actually mean arterial pressure minus the CVP. The CVP can be overridden by local pressures such as intra-abdominal pressure, which can be higher than the CVP, or even ICP in the brain. There's this vascular bottleneck which we need to understand, that as the caliber of the vessels decreases, as the caliber decreases, I'm sorry, you can see in the left ventricle, as in the left ventricle, the pressures, they are like 120 and they approach zero. In the aorta, it's at 120 by 80. The larger arteries, there's a peripheral augmentation, and then with the smaller arteries and arterioles, and then onto the capillaries, there is a progressive decrease in the mean pressure. Then, as the venous side approaches, you can see there is a gradual increase, and if the vena cava pressure rise further, what happens is that there is a decrease in the PMSF, or the systemic mean filling pressures. So long we have always only been driven by fluid tolerance of a patient, depending upon the extra lung water index. For the left side, the ELWI, if between 3 to 7 and associated with normal A lines, augurs well towards perfusion of the patient or giving him fluids. Whereas ELW of more than 10 mils per kg with bilateral B morphology, that was an indicator to stop fluid for administration further. For the right side of the heart, the central venous pressures and the vena cava respirophasic variation, they had been used, but they have got a couple of confounders, such as if the patient is on mechanical ventilation or is on a high PEEP. We need to remember that the events which can cause right-sided congestion are either fluid overload, right ventricular failure, or pulmonary hypertension, which is existent in quite a big subset of our patients. These lead to an increased central venous pressure, which may manifest either as cerebral venous congestion with cardiocerebral syndrome, or as renal venous congestion manifested as cardiorenal syndrome, or cardiointestinal syndrome by way of portal venous congestion. The portal venous congestion, it leads further to endotoxemia, cytokines, bacterial translocation, systemic inflammatory response syndrome, and finally multi-organ failure. So what basically is VEXUS is what we'll be looking at. You see, we have this tracing is the regular tracing that you get to see with the CVP. You've got an A wave because of atrial contraction. A tricuspid valve elevation into the right atrium causes the C wave. The X descent follows it because of the downward movement of the contracting right ventricle. A back pressure from the filling of the right atrium creates a V wave, and finally you've got a Y wave because of tricuspid valve opening in early ventricular diastole. Now, if you just put in a line here, exactly here, and you generate something which is approximate to the waves which are found in the veins downstream in the IVC. Let's look at the heart here. You see this heart, once it contracts, whenever there is a ventricular contraction of the right ventricle, which actually has got a longitudinal contraction, much unlike the circular contraction that is seen in the left ventricle. As the right ventricle contracts, you can see the right atrium, it becomes a lot roomier. It gets a lot more volume, and it is during this that downstream, the IVC gets a chance to drain in there, and that which causes the X descent is visible here. So if we just put it on the, If we just put it alongside, you see here, what happens is that you're getting the A wave, the X descent, and this causes the S wave to appear on the hepatic vein, followed by the D wave. This helps us in actually determining if our patient requires evacuation of fluid or not by way of UROS. This circulatory system figure is just for showing you whether where are the places where we need to probe to know about the venous congestion. First, the vena cava, then the hepatic veins, which is reflective of the liver pressures, the gut, that is interrogated through the portal vein, and finally, the renal vein for the kidney status. The first thing that we need to look at in the IVC, in the vexus, is the IVC. We need to remember that the IVC has always got a collapsing tendency which is antero-posterior. It is, you can see the IVC has got two diameters. It can be either an antero-posterior or it can be lateromedial or mediolateral, however you may call it. So you need to remember that the IVC always collapses in an antero-posterior direction, and we need to always examine an IVC in either a sagittal or longitudinal plane or in the horizontal, axial or transverse plane. The coronal plane is not the right place to examine for the IVC because the collapse of the IVC doesn't occur in the plane that you are interrogating at. So the first thing that we need to see is the IVC. The IVC should be more than 2 centimeter in diameter for us to continue with the vexus scoring. If it is anything less than that, we need to stop right away. This is another figure that I need to show you because the aorta can often be mistaken for an IVC. The aorta is always non-collapsing. It will be pulsatile. You can interrogate by a pulse wave Doppler to further confirm the pulsatility of it, as in a Doppler trace. This hepatic vein is a marker of you actually being in the right place and detecting the right structure, that is the IVC. The IVC in this state of congestion, it assumes a bunny rabbit sign, and as you can see here, there is absolutely no collapse and the diameter is definitely more than 2 centimeters. So this is the first thing that you need to look for in vexus. The second thing that we have to look at is the hepatic vein Doppler. Hepatic vein Doppler, as I showed you in the trace before, the normal hepatic venous trace is much like the IVC trace that one gets to see when measuring for the JVP. You'll see the normal variant of hepatic venous flow shows a S wave which is bigger than the D wave. As the right atrial pressure increases, the S wave will progressively become smaller and smaller. And the D wave, although there is not much of flow actually occurring during that, but as the S wave becomes smaller, there is a relative enlargement of the D wave. Here you can see the S wave is becoming smaller than the D wave. Finally, coming to a point where it is becoming so much smaller that it is very difficult to differentiate whether it's existent at all. And finally, what we get to see is the AS wave, or sometimes called as the SD reversal. So this is all about the hepatic vein. With increasing right atrial pressure, this is how it appears. Second, the portal Doppler. If you see the portal vein has got a respirophasic continuous flow with maximum pulsatility of up to 30%, and that too only in thin individuals. You can find a 30% pulsatility in me. But with increasing right atrial pressures, what happens, you get to see that the pulsatility initially goes up anywhere between 30 to 50%, then it assumes bigger pulsatility, and finally there is a flow reversal and there is a to and fro pattern. The final thing that we need to see is the intrarenal vein Doppler. These are very difficult to get because of the very close proximity of the renal artery and renal vein. You will always get a trace which is both above and below the interrogation line. The renal venous Doppler pattern is much like the portal venous Doppler pattern. It is continuous and it is laminar. But as there is an increasing pulsatility, you will see with increasing right atrial pressures, you will see increasing pulsatility, so much so that at one point in time, what you will get is only a D wave, which is monophasic below the line, which is only present during the diastolic phase of it. Depending on which trace you are seeing, you can either classify each particular vexus finding as moderate, mild, or severe. I'll just take a couple of more minutes now. So this is what we do. Start with an IVC diameter. If more than 2 centimeters, you proceed to step 2. Look for the hepatic venous Doppler form. If there is S wave which is taller than D, then you've got a normal vexus. If your S has reversed, it is mildly abnormal, and in the severely abnormal, you will get a complete S reversal, which will now flow above the baseline. In the portal vein, the normal one is up to 30%. Anything between 30 and 50% of pulsatility denotes mild disease. And for the severely abnormal, you will have a pulsatility which is more than 50%, or it can even go biphasic. Renal venous Doppler normal pattern shows a regular laminar trace below baseline and progressively moves on to being monophasic, D only, in severely abnormal states. So this is what we do. We follow up our patients on a daily basis, and you can see how the change is from the SD, and you can see the pulsatility of portal vein, how this changes over the days. This is from the 24th, this is on the 26th, 28th, and the 29th, all by diuresis alone. You can even appreciate how the Doppler pattern changes of the renal veins, the hepatic veins, as well as the portal vein. Thank you.
Thank you, Dr. Jha, for that lucid insight.